Okay, so good morning, everyone, and welcome to this debate here being held by the Active Citizen Network. Of course, thank you so much to everyone who is here. It's a pleasure to see so many faces, and I hope our friends also joining us online. Thank you so much for doing that as well. Now, today is, of course, a call to action by AHEAD, the Action for Health and Equity Addressing Medical Deserts. In 2020, as I'm sure everyone here is aware, the EU Commission funded the AHEAD project to try to address the challenges of medical deserts and medical desertification in Europe. Now, a medical desert is best described when a community isn't served with the adequate enough healthcare services or personnel. Medical deserts are, of course, a growing problem all across the continent and especially in rural areas, which we'll probably hear much more about. The European health workforce is also facing major challenges due to an aging population, a high demand of new primary care models and better patient-centered care. Today's many crises like the Ukraine war, cost of living crisis, all of these things are also exacerbating the problem as well and impacting budgets. And the healthcare sector as a whole is still, of course, recovering from that awful thing that no one ever wants to talk about, the pandemic. Now, AHEAD's mandate was to define, design and implement evidence-based reforms in health that could help counteract, of course, medical deserts. Projects were set up on the ground in Italy, Moldova, the Netherlands, Romania and Serbia, countries that were, of course, carefully selected to highlight the different characteristics when it, of course, comes to medical deserts. Now, today you are going to hear from a range of experts who are all sat around us all, who will discuss also the work as part of AHEAD. We'll also then be followed by a roundtable discussion. But the most important thing about today is that we are going to open the floor to all of your questions. So please do get involved because that section is about 45 minutes. So you've got lots of time to take the floor to ask questions of all the experts and of each other. But first, let me hand over to our host of the day, Beatrice Covassi, who is the Italian Socialist MEP, for her opening remarks. And also just to add that, there is translation being provided for both English and Italian. Ms. Covassi will be speaking in Italian.
Thank you very much to everybody. I will welcome you in English, but then make my remarks in Italian because I think the topic today is so relevant for my country that it's really worthwhile, spending a few words in the language which can be understood by my fellow citizens.
First of all, I would like to say that I'm very happy and honored to host this event today. And I would like to thank, in particular, Secretary General Anna Lisa Mandorino, as well as Bianca Ferraiuolo, who made this event possible through her hard work and preparation. And I would like to spotlight such a urgent topic today. The AHEAD project we will talk about today is mainly focused on this topic in Italy, but also in other countries, about medical and health desertification, which is unfortunately a topic which is neglected, but we can all see the evidence of desertification, of health certification, overcrowded hospitals, long waiting lists, even for, a very simple medical test. You may even wait more than 1 year for a routine test. So all these aspects are visible in our daily lives. And that is more worrying because that shows that we are increasingly experiencing these issues in having an access to medical services, and that may engender inequalities, especially in the health sector, which is a fundamental right for citizens. And as far as Italy is concerned, Italy is a very clear example of health desertification. We have some data, Jonas, about National Health Service. Italy is losing 7 GPs per day in the National Health Service, and around 40,000 GPs are going to be retired in the next 5 years. That means that we will have a more urgent issue to face. And this concerns GPs, gynecologists, and other specialists. And that is more important if we think about the political scene, because we are increasingly experiencing this crisis, and that means that the citizens spending 350 euros per capita for public health and over 500 euros for private health. And we also have cuts in our budget, and furthermore we may risk to have inequalities in the different areas, because we have different autonomies, different administrations at regional level. And I would like to conclude my contribution by telling you something in a more general way at European level. The European Union has an increased role to play in the health sector, health was not part of the EU competencies before the pandemic, but after the pandemic, after this crisis, the EU has acquired coordination powers, especially for special interventions such as vaccine distributions. But how can we proceed in public health at European level? What is the role we should play even in this area to guarantee an adequate public health level? Next Generation EU has given a positive approach in this area as well, and we have 5.3 billion euros for EU for Health program, and this financing scheme is not sufficient, so we should wonder how to proceed financially speaking in order to take care of public health. And then digital competencies. Digitalization is going on. Telemedicine is the future, even specialists are mapping genome research activities, but that means that we need to have more competent doctors who have a digital culture, and also health staff who could be able to deal with digital tools, with telemedicine and other digital instruments that will be introduced in rural areas suffering from health desertification. So that is really a positive note to conclude my contribution, because that will enable us to create new jobs for the new generations. And I really do hope that we may be able to have a virtuous cycle between innovation, citizens as support, and the role that we all need to play to protect this big and important element that is public health. And I really thank you for your participation, and I really would like to thank you for this ahead report. Thank you.
I think you can definitely say you made some very important points there, especially on the role that the new generation obviously has to play. Next, please welcome Annalisa Mandarino, who's a Secretary at Cittadinanza to take the floor for her opening remarks. Please go ahead.
Thank you. Good morning, everyone. And welcome also from me to this initiative, which intends to explore from a multi-stakeholder perspective the so-called medical desertification phenomenon, an expression with which we have only recently become familiar, but which refers to issues that have been well known for a long time, resulting in substantial difficulties in access to care. These include, for example, long waiting times, a shortage of healthcare personnel, or long distances to the point of delivery of care. The fact that the European Union, through the EU4 Health Programme, has allocated funds to the topic shows the attention that the European institutions are paying to it, but also, and above all, that we are facing a phenomenon that can no longer be associated only with certain regions or certain member states, but that instead affects Europe as a whole, as we will have the opportunity to discuss today. Having said this, the fact that sufficient and adequate measures were not taken in the elaboration of national recovery and resilience plans is a paradox that can hardly be justified. This is at least true for Italy, the country I come from, which represents the nation that has benefited most in Europe from the Next Generation EU funds, because it was the first and the most strongly affected by the pandemic on the European continent. Indeed, the reforms envisaged in the National Recovery and Resilience Plan will only have the desired effects if the investment in health facilities is accompanied by an adequate investment in the health workforce. The inconsistency cannot go unnoticed. On the one hand, we owe eternal gratitude to health workers for the sacrifice they have made, also in terms of human lives in tackling the pandemic. And on the other, their legitimate demands have been almost ignored, or at least not considered a priority in the countries of the European Union when allocated the PNRR funds for public health. This is a discrepancy that citizens and patients are paying dearly for, seeing their right to access care restricted, whether it is highly specialized or routine, since the shortage of health professionals affect not only specialists, but also GPs and pediatricians, not to mention nurses and other social health workers. The work conducted within the AID project allow us not only to highlight paradoxes, but also to dispel myths and go beyond easy stereotypes. The medical desertification phenomenon has certainly always characterized the inner areas of the most member states, but it also does not spare the more developed and densely populated areas. It is therefore as much a rural as an urban phenomenon. The COVID-19 emergency has only exacerbated the phenomenon, but it is certainly not its genesis, which means that once the pandemic emergency is over, we will still be dealing with the emergency caused by the medical desertification phenomenon. Hence, a far-reaching commitment, which we hope will be considered a priority at European level in the aftermath of the next elections in May 2024. Also because without an adequate strengthening of the foundations represented by a relaunch of the health professions, it is difficult to follow up and give substance to the aspiration of the President of the European Commission, Ursula von der Leyen, to start building a European health union to protect citizens with high-quality care in a crisis and keep the Union and its member states to prevent and manage health emergencies that affect the whole of Europe. In analyzing the characteristics of the phenomenon, including the quantitative ones, we came up against a reality that makes the situation even worse. The lack of reliable, up-to-date, and easy available data on health personnel. This, of course, makes intervention planning even more complicated. Here, too, I'm sorry to say, Italy was found to be the country most lacking compared to the others represented in the project. What is most worrying is that at this rate, the very existence of the national health services as we have known them until now is at a risk. According to analysts, the phenomenon of medical desertification has more the appearance of an imperceptible melting glacier than the thunderous resemblance of an earthquake. And in this sense, to bring you once again a testimony of the reality I know best, in Italy, this process is eroding the very foundation of national health system, which was founded on the principles of universality, equality, and equity. Will these principles still be guaranteed if the medical desert will not be stopped? The presence of the experts called upon today will certainly also be of help in advancing towards a necessary qualitative analysis at the European level on the motivations that have driven many ACPs to give up their work or have self-limited themselves to practicing it on demand rather than having swifted from the public to the private sector. We perceive the risk, which must be avoided at all costs, that in the near future health will no longer be perceived as a common good, that healthcare will be increasingly privatized, and thus the use of care will be increasingly correlated with people's financial resources rather than their unmet medical needs. A scenario that, as far as we are concerned, terrifies us, driving us to call for a great popular demonstration to protect and safeguard the national health systems in each member state. In Italy, we are organizing it for May. We are confident that the proposals, as well as the concerns that will be socialized here today, can be brought to the attention of the members of the new subcommittee on public health. For our part, we will certainly also involve the MEPs of the interest group European Patients' Rights and Cross-Border Healthcare. I end by thanking again, the hosting MEP Beatrice Covassi for her sensitivity to today's topic, and I wish you a fruitful meeting.
No worries. These little buttons are a little bit fiddly, so yeah, just keep pressing. And if your button doesn't actually, your microphone doesn't go on, please ask the person before you to unpress their button. Okay, brilliant. So we've been hearing a lot about the kind of, setting the scene, what the picture is across Europe. Let's learn more about the HEAD project. Aysel has, oh, there she is. Okay, so you switched seats. Okay, so let's hear from Aysel Rahimli. She's the project coordinator at HEAD and Pillars of Health. And she has this presentation for us. Please take the floor.
Thank you, Miriam, and great to see you all, colleagues. Indeed, as a project coordinator, I have the honor and the privilege of opening the discussion with a brief introduction for the project to set the scene and let you know what we got up to in the last 2+ years. But before I dive into that, let me first start with thanking the consortium partners, many of whom I can see here in the room today, and some have joined online. I also want to extend this to a huge number of participants of the project, those who were involved in many of the activities, including in the project countries, but also those that work on the EU level as well. And we're grateful for your time, expertise, experience that you have shared with us to have shaped the results of this project. Of course, I also want to thank the European Commission for co-funding this project and Beatrice Covassi for the opportunity that we have here today. So a big thank you to everyone. And now I want to dive at the issue at hand, indeed, to highlight some of the things that we knew before the project even started. That is that the COVID-19 pandemic highlighted the exacerbated inequalities and the differences among the EU member states' health systems even further. We all know that the healthcare workers were facing the challenges that you can see on the screen, the shortages, maldistributions, undervalued work, the aging workforce, and the population. And we all know what this has caused. Particularly, it's important to highlight that the maldistribution between the regions for the density of the physicians in the EU member states was more than fivefold. And moreover, I want to also highlight that the EU State of Health Companion Report that came out in 2021 brought to the attention that they need to rethink health workforce strategies across the Union as well. This report stated that almost all European member states faced a challenge in the recruitment of the health personnel, particularly physicians in the rural areas. There was country-specific strategies and policies that were implemented, but to quite a varying level of success. And so with the ahead results, we work towards solutions to these issues and from the medical desert perspective as well. But let me also take you back to spring 2020, when the European Commission launched a call for proposals under the third EU health programme, with the aim to support the reforms in the health workforce field. The call for proposals has specifically asked the initiatives to have an objective to provide support the member states to design and implement their policies related to healthcare workforce retention, task shifting, and the regional medical deserts. This should be achieved through development of supporting tools, guidelines, scaling up of good practices, and creating a platform for policy dialogue to advance these challenging issues. And to kick it off, the European Commission has shared a short definition of medical deserts as guiding principle, which you can also see on the screen. And some of the key highlight words, I guess, would be the isolated or depopulated areas, low concentration of services, falling number of practitioners. So our first challenge in ahead was to come up with a more concrete definition, something that would be a bit more tangible. We soon realized it was quite a challenge, also because our countries are quite diverse, as was mentioned, in their context, and as the European region is as well, which we realized was the beauty of it, as well as we concretely identified all the contextual elements are really the paramount to this work. So we came up with a short definition that you can see here on the screen as well, and it reads that a medical desert is the endpoint of a complex process called medical desertification that implies continuous and increasing inability of a given population to access health services in a timely and contextually relevant manner. On the HEAD website, you'll be able to see a full page that explains this a bit further and provides a more detailed explanation of what the terms mean for each context as well. I also want to present to you, summarize some of the guiding principles of the project that we had, which is, as I said, context is everything, and we need to tailor all of our interventions to the local needs. It's especially important for data collection and the availability of the specific indicators, which was quite diverse in our countries as well. Of course, this affects the methodologies and the conclusions and comparisons that can be made. It's also extremely important to engage those that are affected. That means the isolated communities, the health professionals, and everybody who knows the lived reality. Finding consensus to have an agreeable, feasible, acceptable policy measures is to implement an efficient and effective policies was also key. And we based all of our interventions with the aim to produce practical tools for the policymakers, which are unique selling points of this being interactive maps of the project, medical deserts, and as well as implementable consensus building methodology. So just to briefly explain our medical desert diagnostic tool, the one I just mentioned, which is a publicly available tool that is on our website and can be used by anyone. This comprises of a set of features that together can identify and illustrate where the medical deserts can be found, and if implemented the same way, the methodologies that we also made available on the website. For now, of course, the tool is focusing on the project countries, and which you can see highlighted on the map as well. And in a nutshell, it contains illustrative story of the lived realities, a report on medical deserts per project country, and a selection of indicators for a wider context setting, and lastly, maps that are based on a contextualized set of indicators that highlight the high-risk areas. And what to do then when the medical deserts are identified? It is, well, the aim is to find solutions to the policy solutions in those areas, and do so by implementing the consensus building methodology, another unique selling point of the project. We piloted it in all the case study areas and evaluated the process as well. In a nutshell, this methodology was used to firstly obtain a general agreement among the relevant stakeholders on the most appropriate policy solutions for the local context. It does not mean that the concept of it does not mean that there's an agreement with every aspect, but to have a general agreement that the options are the right ones and something everybody can support. Our project focused on options that for the wide range of locally developed innovative solutions. And we do know that this process does lead to better decision-making by involving different stakeholders, ensuring they're contextually tailored and sustainable. The policy solutions that came out of these sessions can be summarized into being technical, so availability of data and developing strategies, but also somewhat political in aspects as well, having political commitments, etc. We also, what we want to highlight here is that we discovered they can be categorized further into, first, actions that fall within the Ministry of Health directly and implemented on a national level. Secondly, they also lead to actions that require close collaboration with a diverse set of different perspectives and different participants, including other sectors. And there's also actions that focus on empowering those from the local communities, especially the areas that are or could be considered medical deserts now or in the future. And there was one cross-cutting theme of governance, which can be interpreted also as ensuring that there is a technical and a physical capacity to, firstly, assess the localities and identify the medical deserts, and secondly, take action to mitigate them and escalate to national stakeholders when needed. To create such capacities, member states have the responsibility to allocate appropriate funding, so via national domestic funding streams or using those that are available on EU level. And this can only be done if there's a political will, and which is beyond the political cycle of the politicians. This funding should be made available also in light of ongoing regional developments. And an important advantage of using EU funding is that it creates a stronger incentive to ensure accountability and the sustainability of the solutions as well. So, as these themes were discovered, it was also an opportunity for us to use these findings to call for those in power to go ahead, act now, and tackle medical deserts. So we drafted a call for action document, which can be also found on the HEAD website. It's a 3-page document, and I have limited time, so I will highlight only some of the key actions that we are proposing to specifically the target groups that you can see on the screen: the European institutions, the member states, education institutions, health professionals, and of course the citizens. To start with the ones for the European institutes, firstly, it's important to elevate the political agenda and to make medical deserts a top priority throughout the Commission's mandate and also beyond. And of course, like I said, political willingness is key to that. Secondly, use and apply available data and tools to fill the gaps that is available and is meant to be collected as well. And funding is key to mitigate this societal issue. And funding instruments need to be more accessible and widely shared. And it's also important to map and report how these resources are being used directly to address medical deserts, which ensures accountability. For the member state governments, the national level actors, our ask is to firstly improve the quality and the systemic data collection and the analysis of it, and to use the available tools such as those developed as part of the HEAD project. Create dedicated task force with a capacity of both physical and technical to develop, implement national strategy and of how to identify and address medical deserts. Thirdly, to recognize citizen participation as a founding principle of the national systems, health systems, and apply a multi-stakeholder dialogue methodology, such as the one I presented on the consensus building that we developed, to increase context sensitivity, applicability, acceptability, and the feasibility of the policy solutions. And fourthly, to increase investments in health, education, economy, and connectivity by involving a diverse set of actors and sectors as well. For the education institutes, the ones responsible for the health workers training, there needs to be a continuously adaptation of the education of the health and care professionals to the needs of the population and the health services, especially for the most vulnerable, with a specific attention to those that live in the rural and remote areas. And implement or improve task shifting practices and across all cadres and update the digital skills of the healthcare personnel. And thirdly, to ensure continuous education and the professional development with a particular attention to those practicing in rural and remote areas. And last but not least, it's important for that the healthcare workers, their associations, the citizens, and their advocacy groups are actively participating in co-creation of these policy solutions, advocating to the right for health for all, and creating further awareness on needs of the most vulnerable, including populations in the medical deserts. Like I said, you can find a full list of these actions on the HED website on the results page. And thank you very much for your attention. I'm looking forward.
Perfect. Thank you so much, Hazel. I think it was great that you brought up data analytics and, of course, the political will. Okay, now we're going to have everyone just look at the screens because we have a video from Thomas Zapata, who Unit Head, Health Workforce and Service Delivery at WHO's European Regional Office. Please take a look at your screens. Don't worry, guys, the video, I'm sure, is worth it. Yes, it is. I think this room is a little bit cursed when it comes to the technology, so don't worry. Yeah, yesterday we had a problem with the web streaming, and then obviously these little microphones are a little bit fiddly, so, and now.
And we talk about telemedicine. Be careful, we really have to get the digital skills right, okay? And the supporting infrastructure.
Exactly. Or maybe for the video, we should all learn, lip reading.
Yeah.
But we're going to get there, so don't worry. Just hang on. Oh, okay, no worries. Okay. So hopefully, if we've got time, we might watch this video a little bit later. But with that, as this lovely video plays on our screens, let's now kick off the first roundtable discussion. Okay, so first of all, we have Kazia. I won't pronounce your surname. The Policy Officer, DJ Sante at the European Commission. Lovely to have you with us. Thank you so much. We also have Marina Roy de Blas, who's from DG Agri at the European Commission. Welcome to you too. Dorota Tomalak, the Deputy Head of Unit at the European Committee of the Region. So we have so much official EU representation here. That's fantastic. We also have John Wynne-Jones, great sounding name, John. Yes, hello, John, who's the past president of the European Rural and Isolated Practitioners Association. And then we have Paolo, who is sitting over here, Micheluti, who's the leader of the EU Joint Action on Health Workforce for Health Challenges Heroes. Welcome to you all. So what I'd like to do is to allow each and every one of you to take the floor. So Kazia, please go ahead.
Thank you so much and good morning to everybody. It's a great pleasure to join this meeting and to be part of the discussion on what we do with this very interesting results and valuable work of our AHEAD colleagues. I'm also very sad because this project is coming to an end, and it has really been a great pleasure and very inspiring experience to work with the whole AHEAD team to follow this work. So congratulations, first of all. I think that, yeah, we reached very interesting results. We learned a lot about countries which were part of the analytical work under AHEAD. And yeah, we know very well that only 5 countries participated, including 3 member states, 3 EU member states, but we know that the challenge of medical deserts is there for many more. At least half of member states face the persisting challenges in terms of ensuring equal access to healthcare. Due to some territorial problems, distribution of health professionals, but also broader solutions when it comes to the accessibility and effectiveness of health systems. So these challenges persist. So I think that what is very important, and I appreciate today's opportunity, is to think about the effectiveness of the solutions which have been taken, because we have many member states who had taken some measures in the past, but we see that they are not necessarily always effective as we have to live and continue with the challenges. So I think that this is really a very appreciated opportunity to discuss it and reflect a little bit on it. I think what I also would like to stress, looking at the results of the project, is that we have to keep in mind that medical deserts are not only rural, as it was already said, but we also have to think more broadly that medical deserts are not only medical, they are social economic deserts, basically. And I think what is a very interesting outcome of this project is that colleagues find a good way to invite around the discussion table various stakeholders at local level, involving various sectors. I think this is really a very appreciated effort. I would like to highlight it because we tend to work in silos everywhere. And I think that without reaching the right stakeholders at local level, ensuring the bottom-up thinking on the solutions and trying to be reasonable and see what is feasible in terms of policy solutions, that without it we cannot really reach a progress. And that brings me to the point on how we can help at EU level, but how we see the solutions. I think that the important solutions should come from the grant. This is clear. What the project shows is that that challenges are very different in 5 participating member states. There are some similarities. We clearly see that the important aspect of attractive health professionals to the underserved area is to improve the systemic solutions. And this is clearly what the Netherlands case study and Romanian case study show, and they very much highlight, and I would also like to highlight it, the role of primary care. They show different challenges in both countries, but I think that we have challenges across Europe. That's why we are also having another initiative, a joint action on good practices in primary care. But I think it's very important to highlight that, we have to look at each and every system, each and every country, because as the results of the AHEAD project show, challenges are different. So the ways to improve primary care would be different in the Netherlands. What I found interesting is that, for example, we should be prudent in applying mandatory deployment measure to set up rural practice. We were thinking of it, how we could eventually build some mechanism through EU funding, but I take it that this is not necessarily always a good solution. Why in Romania we see challenges with the regulatory improvement of primary care through creation of multidisciplinary practices, recognition of value of primary care teams, recognition of role of nurses, changes in education and upgrading telemedicine. So we have to be aware of the spectrum of challenges and be very critical about what problems we need to address on the ground. Another issue related to the systemic improvement is also the whole environment related to the working conditions and the right incentives to attract and retain health professionals in underserved areas. And this is also a very vast area. We have other projects in the cluster in which this particular HEAD project was included, who also look at these problems. So yeah, we are looking forward to the results, which will be clear next year. But we also, this issue is also part of our discussion and policy steering role in cooperation with member states. So we, of course, use the European semester as the kind of policy steering tool. And in the last 2 semester cycles, we addressed the issue of shortages, but also working conditions in the policy recommendations to member states. So this is the issue of the very delicate share of competence. Here we cannot always step into the competence of member states, but we do encourage the efforts there. And I think that it will be interesting and important to show the conclusions from this cluster, what we could show as good solutions and share it in the wider community in the EU. Another issue is the motivation of health professionals. Of course, choosing the profession comes with the certain sense of vocation, noble vocation to provide care. This is something important, but I think that here we may destroy it. If the system is not right, as I said here, we have to look at the system. We may destroy this motivation because we will see the health professionals overburdened with work, stressed. So I think the motivation, there is something about creating the motivation of young people, so attracting them already at the stages of their education, but also keeping them. So to keep the professionals attractive, I think it's part of the very personal inspiration to work, for example, in rural areas, but I think it's also about creating a certain inspiring environment, not to isolate these people, make sure that these areas, underserved areas, are in a way vibrant in many ways, not only as the professional place to exist, but also, yes, as in terms of social condition, access to services, culture, and so on. So this is very important, and I am also very glad to have colleagues representing other policies, other sectors. I think this is important an important step to bring it to the wider discussion. Yeah, I could talk a lot about how this work will fit in our work at the Commission level. So we have Paolo, he will talk about the joint action, a very important initiative on our side. We have also skills initiatives, and I see George here who is leading our Be Well project. We are also starting the big training initiative focused on digital skills. So we have 7 projects which were selected for funding. And we have Claudia here, who is our manager on the agency side. So I am very glad to see so many familiar faces and to have the opportunity to bring also other aspects in this for this important topic, because I think that we need to think really broad and involve many other stakeholders. Thank you.
Thank you so much, Kasia. Over now to Marina, please.
Hello, good morning, everyone. I'm Marina. Yes, I work in DG Agri, and you might wonder why they invited DG Agri. Well, I work in the unit in charge of rural areas and networks, and we are implementing this communication that is called long-term vision for EU rural areas. At some point, we realized there is a certain discontent of rural areas, and they created this the vice president in charge of democracy and I'm sorry. Yeah, no. Well, let's go. Sorry, I'm just a mid-moment. Okay. Rural areas. This lack of services that we saw in the public consultation and that we've seen in different reports. And you wonder, like, I see for the result of this project that the demographic, I apologize, the certification of health is not only in rural areas, but also in urban areas. However, one of the points that was important and interesting that our colleague mentioned is this need of making rural areas more attractive. And that's what we are working in this vision. With this vision, we have an action plan that we are implementing actions for different sectors, but we have also a platform, well, not a platform, more the Rural Pact, which is a space for rural actors to also put things higher in the European agenda. So I also invite actors from the medical desert environment to join this platform, because we work with different member states. We work with also a stakeholder from all levels to put higher in the political agenda all these topics, and also to share good practices, because at some point we don't have so many competencies, at least, but we can work for rural areas in this topic. And I think later on in the debate, I can highlight other elements. Thank you very much.
Okay, next to Dorota.
Thank you, everyone. So I'm the last EU institution representative here. I come from probably one of the smallest institutions, the European Committee of the Regions, who is nestled just behind the Parliament, right around the corner. And what's interesting about the Committee of the Regions is the people, the members. These are roughly 350 plus alternates, so we're taking that up to 700 local politicians. So it means your local mayor, the councillor from your county, your regional president. And it's the diversity that is particularly interesting, because you have a mayor from a tiny hamlet lost in the middle of Hungary that nobody can pronounce the name of, with more sheep than humans actually to govern. And in the same time, you have the president of Bavaria, who probably has the higher budget than the Czech Republic. So these people with totally different experiences, life experiences, power experiences, competences, they come to Brussels about 5 times a year for commission meetings plus 5 for plenaries, and they bring their knowledge, their experience, their expertise, their hopes, their wishes, and complaints. So they're not based in Brussels, they're still in their constituency, so they're still very much attached to their people and working with the citizens. Now, I'm saying all that also because the commission that I particularly work for brings together 2 very important policy competence that we were discussing today: public health and rural areas. So these 2 experiences are fairly important for us today. And I'm making all this introduction to also to highlight that health systems that, well, first of all, we don't have a health system in Europe, we have health systems. And even that is still very much misleading. We don't have national health systems in a lot of member states. We've done several reports actually over years to check what's the situation on the ground. And in 2/3 of EU member states, you have a decentralized health system. And now that also is a bit of a problem, because when you say decentralized, as an Italian, you think, aha, fully decentralized. But actually, as an Austrian, you would see it a little bit differently in terms of competence, in terms of funding, delivery, inspection. So you have to really look at different we look across 5 different areas to see the degree of decentralization, because you may, for instance, own a hospital, but you'll be getting the money from your capital to run it. Or you can actually be paying for hospital care, but not owning the building. You may own it, but the inspectorate will be based somewhere else. So there are different variations and different ways in which you can actually understand decentralization. But in the end, does it matter? Well, for researchers, for sure. But in practice, it just means that you need national level, you need European level, but you also need local and regional level, because without these politicians, without these inspectors, without these healthcare professionals at this level, you will not achieve any change, any proper transformation. And I'm saying local as well, because you also know that in some countries, I'm thinking mainly here, Finland, up until last year, it were actually municipalities that were in charge of social and healthcare. The major reform that's been ongoing for, well over the decade, and I think 6 governments were attempting to actually move forward in bringing the healthcare to the county level. And even there, the discussion is it sufficient? Should we take it somewhere else? Will that be okay to provide proper healthcare for Finnish people? So now, taking that to the discussion, to the topic of today, are medical deserts a fact? Well, I think we can't really say they aren't. They are. Are people aware of that? Well, this is the big question. And I loved the term you used, the glacier, melting glacier. I think this is the excellent visualization of the problem. And I'm saying that also because when I started researching for this team, I thought, okay, well, désert médical, fair enough. Medical desert, great. Can I say it in German? I can't. I mean, I can, because there is a translation of that term, but is it really used? Not really. You would talk about Versorgungswüste, maybe, so the problem of supply, but not necessarily on the medical side. Can I say it in Polish? I can't. I mean, I can translate, but it just, if you hit it in Google, 0, 0. So, and is Poland exempt of that problem? Oh, hell no. Just looking at the recent data, 13 Polish regions reporting on their hospitals, 10 actually had to close at least 1 hospital ward in the last year. So we're talking huge majority, really, but there is no political discussion whatsoever. And for the Committee of the Regions, I've been working on public health issues for the last 11 years at the committee, and I haven't heard the term once. Well, it may simply mean that we haven't had it on our radar, but I think it's a reflection of the general state of awareness among local politicians. They will occasionally say, we're struggling with long-term care, or there is a hospital closing in my village and it's a big issue on the employment side. But as a general policy debate, it just hasn't been happening. So I very much thank you for this event today, for the study and all the tools that you've been presenting, because I think we will very much want to take that forward in our discussions at the Committee of the Regions level. And of course, we hear that a lot from our members, just the bits and pieces of what you've been mentioning about the regional imbalance in terms of distribution of doctors. We hear problems that are not simply just on the medical side. I can't get a doctor to come to my village. Is it a problem of lack of doctors? Maybe, but maybe it's a problem that your village does not have a train connection. So is a problem medical, or is a problem transport, really? Or is that problem maybe of educational offer? If you have spent anything between 5 and 15 years to actually get trained as a doctor, which you would probably be doing in a larger city, where you can have your favorite theater, you can have a great school for your kids, your wife can actually be working, and then suddenly would you move to a hamlet with more sheep than humans? What would your wife be doing there? Where would you send your kids? How would you be visiting your patients if you don't have a driving license, for instance? So all these considerations are not necessarily medical considerations, they're really services consideration. And this is why the long-term vision for rural areas becomes so interesting and so relevant for us, because a lot of issues are actually more on the technology side, on the services side, on the legal side. We've been mentioning telemedicine quite a bit already today. And actually, it's great to have the opportunity to consult a doctor online, if you want to. But then you also, obviously, you need to have broadband, you need to have internet that would enable you to do so. You need to be literate enough to do it. I'm 40, so I'm probably sitting between this, analog and digital generation. So I did stuff without internet, and I know how to use internet. And still, actually, a lot of these new apps, I don't have a clue what they're for, how to use them. And so how would you explain the whole concept to somebody who's 80? And we know that rural areas or remote areas have, looking at demographics, a higher share of older people. So you have a patchy at best internet, and you've got older population. And if you don't have that educational offer for people who have finished their studies or their school 60 years ago, well, where will they learn that? Who will teach them? So these are the problems outside of the sphere of the medical area. So, of course, we've been looking at some possible solutions. And of course, the solutions are, again, coming from a lot of fields. So we have, we know that a lot of countries have been experimenting quite successfully or less successfully with telemedicines. So here, the legal changes were also necessary. So we had to change laws enabling, for instance, reimbursement of teleconsultations. That has happened a lot during the pandemics. Some countries have, said, okay, well, from now on you can do it. Others said, okay, you can do it, but only if you know the doctor or the doctor knows you. Others said, okay, let's just scrap it all together because we need to deal with that. So you have the legal changes that have to be done at the national level quite often. You have some other solutions that were tested, such as booths installed in pharmacies. I think France has been experimenting with that a lot. So if you can't measure your vitals at home, you have a booth at the pharmacy where you can come, and the pharmacy will take some of your vitals, transfer to the doctor, who will then have maybe a fuller picture of what is happening with you. And we know that there is a shorter distance to the nearest pharmacy than there is to the nearest doctor in quite a lot of places. So this is one of the solutions at, let's say, the technological level. But also, technology is a solution, but it's just one of the solutions. During pandemics, we saw a huge increase in teleconsultations in France, for instance. I think it's 150 times more consultations from 2019 to 2020. But of course, who was doing that? Younger people and urban-based people. You have like 17% of these consultations being made from Paris, and about 2.7 from a department of Creuse, I think. So again, it's a solution, but maybe for a certain parcels of people. And I'll stop here because I've been talking for a long time. Cross-border. This is also one of the solutions that is probably worth exploring, because we know that a lot of depopulated or remote or rural areas are on the borders, and it may be super far away to get to your nearest hospital in your own country, but there may be a big facility or a family doctor right across the border. So making this more accessible, more popular, and especially better solved in terms of financing is probably one of the solutions that I would be definitely pleading for. I'll stop here, but I'll be happy to go longer on the calls later on.
Thank you so much. I like the fact that you brought up the telemedicine. I mean, the last time I spoke to my GP, I didn't actually get a GP. I got a medical student. And that was the last time I've spoken to my GP. So there you go. Next over to John.
Can you hear me? Great. Thank you very much. Miriam, you particularly asked whether we could keep our powder dry and not go for too long at the beginning, just introduce ourselves. So I'll just give an overview. My name's John Wynne-Jones. I work in 2 universities in the UK. I co-founded back in 1997 EUREPA, which is the European Rural and Isolated Doctors Association. I think we've moved on from there because we're very much aware of what happened in Astana and the fact that healthcare is now provided by teams, by complex teams. You know, it's no longer you have just a GP in an office, you've got a complex team, and they're dealing with complex problems. I think, and I can't give you the exact data, but it's something like 60% of people over the age of 70 have got one chronic illness, and over 50% of those have got two. So actually shifting tasks doesn't necessarily work, because the GPs now end up dealing with really complex problems where you have comorbidities. So I'm here to represent all those people working on the shop floor in rural practice across Europe. And I've been doing it for 35 years, so probably I'm the only person here. I think there's one other clinician over there, but certainly nobody's got 35 years of experience. So, you know, it's important that you listen to the people that are working on the shop floor, the people who are working there. I've heard a lot. I've actually spent quite a lot of time just going through all the projects that are happening. And there's a lot about policy, but actually you can't just have top down, you have to have bottom up. You have to start at the bottom as well. Listen to the professionals, listen to the communities. That's very interesting that my colleague, Professor Roger Strasser in Canada, when he started a new medical school, he went to the communities and said, what kind of doctors do you want? You know, tell us. And what we want to do is make a pact with you so that actually you will be involved, you will be engaged in that process. So we'll send you students, you look after them. So it's about engaging with the communities. And one of the other things is that you can't have a one-size-fits-all, because rural communities are different. Going back to Roger Strasser again, he said, when you've seen one rural community, you've seen one rural community. They're very, very different. So it's all right talking about policy, but in fact, you can have as many policies as you like. But if people don't want to work in rural areas, they're not going to work, and your policies are not going to work. So you have to produce a workforce that wants to work there, and a workforce that's fit for purpose. A workforce that actually knows how to deal with some of the complex problems you're going to have. It's about managing complex diseases. It's about managing emergencies that urban doctors don't have to deal with because they have an ambulance that comes straight away. It's about stabilizing really sick patients. So your workforce has to do something that's different, a wider range of skills that they have. And it's managing things at the periphery of care, because these people will be working at the periphery. And also, I must say that people working in some of the no-go areas in big cities are also working in the periphery of care. And I want to just quote Roger Strasser once more. He said, one of the problems is something called urban narcissism. And the fact that, you know, most of the places that actually, most of the institutions doing rural research are based in cities. All the universities that teach the medical schools are based in cities. What we need to do is to improve the status of rural practice. So people can say, actually, you know, I'm proud to work in a rural area. You know, this is my first career choice. Now, some of that has already happened in Australia, but I've got one warning for you. It's going to cost a lot of money, and it's going to take a lot of time, because the time taken to train a doctor, to train a nurse, to train an occupational therapist, to train a pharmacist is a long time. So we've got to start. And perhaps if I've got time, I can give you my kind of plan later on about how we do that. But I think we have to remember that we're dealing with up to 30% of the European population, depending what country you're in. This is a large number of people across Europe. So it's not just a small minority, it's a significant minority. And one more plea that I really have to say here is that, you know, when somebody goes to access the health service, they access it through primary care. 90% plus of all kind of consultations happen in primary care. It's a very small amount that end up in hospitals. And yes, I hear about people saying hospital this, hospital less. It's primary care that matters. And we know from the work of Barbara Starfield in Johns Hopkins, and this was a lifetime of work that she did, the countries that have the best primary care have the best health outcomes. So we need to move that into rural practice. So I think I'll probably keep my, I think I've said everything that I need to do in my introduction there, Miriam, and I'll keep my powder dry for the discussion. Thank you.
Thank you very much, Miriam, and thank you for the invitation. I'm Paolo Michelutti, and I work at Agenas, that is the Italian agency for the regional health services. So we are quite used to work with the decentralized health systems. And I'm a project manager. I worked in the health workforce field for more than 20 years. And from 2012, specifically in health workforce planning, both in a European project and also at the national level, supporting the Ministry of Health in coordinating the health workforce planning system in Italy. And well, since the 1st of February, I'm the coordinator of this new joint action called the HEROES, Health Workforce to Meet Health Challenges. And well, basically, the aim of this joint action, that it is a 3-year project involving 19 European countries, is to improve the capacity of the member states to plan for their health workforce. And well, and the health workforce planning basically is or can be an effective health workforce planning, can be a solution to avoid the medical desert. Okay, of course, in the future, because we're talking about to plan in the future. So it's a strategic activity for all the countries. So that's why it's important to improve the capacity of the European countries to plan for their workforce. I can just mention, well, 3 challenges, okay, for the health workforce planning in the European countries. Well, first of all, data. You all mentioned about the lack of data and so on. We needed data. In my experience, I think that we already have a lot of data. The real challenge is to put the data into action, basically. So to use the data, that's the real challenge, okay? And that's one. The other challenge that you already mentioned several times, the stakeholders' involvement and engagement, okay? So both because we needed to involve national and local stakeholders, okay, in plan for their workforce, because all the stakeholders have interest, but also power. And it's important to plan also at the local level, not only at the national level, because most of the times the solutions are at the local level, as John said. And it's tricky because there are a lot of stakeholders, a lot of regional competent authorities and so on. But it's important also to involve the health workers. Okay. We always mention usually medical doctors, sometimes nurses, but there are a lot of type of health workers or health professionals. Okay. For example, I'm from Italy. In Italy, we have 30 recognized health professions. Okay. These are the ones that are recognized. It means that in practice, there are more type of roles, but the recognized are 30, including vets, for example. So when you talk about the ships in Hungary, it means that this is something that has to do with the health workforce planning, okay? And of course, also it's important so to talk about what the appropriate skill mix, not the appropriate numbers of certain type of health professions. The third critical issue, well, we are here in the European Parliament. So are the involvement of the politicians, because of course, all this type of activity to put the data into action, to involve the stakeholders are more, let's say, technical activity. But at the end, these activities are useful to take the decisions. And policymakers usually take the decisions. But when we talk about planning, especially for the health workforce, we are talking of something that we need to decide now, and the effect will arrive in, let's say, 10, 15, 20 years. Not today, not tomorrow, because if you need more medical doctors, more specialized medical doctors, well, you need at least 10 or 12 years. So the challenge is to help the politicians to well communicate it to the citizens, the reason why we are going to take some decision now that will have their effects in the future, and can be also maybe not so popular decision, okay? Because maybe it's a popular decision to increase the number of student intakes in the medical schools. But if you are talking about improving the shifting, for example, between nurses and doctors, well, maybe this is not so appealing for the citizens, or to improve the connection between the health sectors and the social sector and so on. But these are most of the time the most effective solution. Okay, I will stop. Yes, otherwise I will take all the time. I'm sorry.
Okay, so it looks like the video is loaded. So just watch the screens for a few minutes and we can watch Thomas Zapata from the WHO Regional Office and his video message for us.
Thank you so much.
There we go.
For the invitation to be presenting here the work and on health and care workforce that we are doing in WHO Europe and presenting a little bit of the situation. Last year, we launched the regional report, Health and Care Workforce in Europe, Time to Act. The report described the main challenges on health and care workforce in the region, described some good practices, and presented data of 53 countries in the region on health workforce. And in addition, it presented 10 action points for the way forward on how to improve and strengthen the health and care workforce. So some of the findings, what we see in the report is that from 2010 to 2020, the availability of doctors has increased by 14% in the 53 countries in the region, and by 8% for nurses from 2010 to 2020. And at the same time, the production of doctors have increased 37%, and the production of nurses has increased by 26%. So basically, what we see is that we have more doctors and nurses than ever in the WHO European region, and specifically in the EU countries. But at the same time, we are seeing how the doctors especially are aging, and we have a very old doctors workforce. So we see like in 11 countries in the European Union, at least 40% of the doctors are over 55 years of age. That means that in 10 years, at least 40% of the doctors will go on retirement in these 11 countries. So this really poses a challenge, and that's why we were talking about time to act, or even a ticking time bomb, which was taken by the Guardian article and reference in our article. Then we also need, the report also came out data on sex distribution. We see how half of the doctors in the region are already women and increasing. And we know that the nurses are mainly women, 89%, and midwives, 98%. And in total, 2/3 of the health workforce are women. So we really need to take into account the gender dimension when developing policies. And now we are working as WHO in developing a framework for action that will be presented in the regional committee in October in Kazakhstan, in Astana. And that framework for action really puts the health and care workers at the center of the framework, putting their needs at the center. And the first thing we need to do is improving retention of health workers. So we are able to retain those health workers, because despite having high number of health workers, we know that they are aging, we know we have issues of migration, we know that we have issues of burnout and health workers leaving the profession, attrition. So we really need to improve the working conditions to retain, to keep those health workers in the system. And that's why it's so important, not just having a fair remuneration, but having flexible working arrangements to find a work-life balance, in having taking care of the mental health and well-being of the health workforce. All these issues are really becoming important. Another important issue that you are discussing is improving the recruitment and retention of health workers in rural areas, which is a major priority and is one of the key actions in our framework. And also we need to look at, as I was saying, improving the health and well-being of the health workforce, and that came out very strongly after the COVID pandemic. And also migration, we see how migration is increasing globally, and some EU countries are really attracting a lot of health workers from different systems into the European region. And these dynamics, I think that those are dynamics that we need to look at, and look at the triple win and taking into account the WHO code of practice, the triple win between the source countries, the destination countries, and the individuals. Anyway, in terms of way forward, 3 weeks ago, the WHO regional office organized
Did we not want to speak to him anymore? No? Goodbye, Thomas. Okay. Oh, he's back. Okay.
setting up the principles to strengthen health and care workforce in the region. And then, as I said before, we will move into a resolution in the regional committee in October. Thank you so much. And as a summary, I would say that health and care workers are at the heart of the system, are the beating heart of the system. And if we want to improve access and quality of health services that are responding to changing needs of the population, taking care and caring those who care is critically important. Thank you so much, and looking forward to keep discussing in the future. Thank you so much.
Okay, fantastic. Okay, so we don't have too much time. So what I'm going to do is I'm just going to ask a few questions based off, your sort of interventions and your opening comments. So Kezia, coming to you first. I mean, obviously, everyone is talking about what the EU can do, obviously as an EU representative as well. Within that context, then, how important a roadmap would you say that AHEAD really provides? I mean, obviously, we don't have the findings yet, but how important is it within the context of having a European dimension or solutions?
I would say it is critically important. And the timing is always good because you know that we work on in the framework of the European semester, which is the annual process. So each year we assess the effectiveness of health systems, accessibility as well, of course, and we try to make certain recommendations, country-specific recommendations to member states. So each year we look at various topics, and I must say that since last 2 years, health workforce is really one of the topics #1 in our country-specific analysis in this process. So we, of course, cannot fit the country reports, which are actually at the core of the European semester. We cannot fit these country reports with very detailed conclusions from AHEAD, but we can always, in our policy dialogue with member states, refer them to policy proposals AHEAD would provide us in 1 month. And also, I don't exclude other projects in the future. So this is a living tool for us. It's not by coincidence that we put some budget to this kind of actions. Of course, there was a call from some member states to do it. I don't hide it. I know that I was not there when the call was designed, but I know that there was a strong interest indeed from a few member states who face the challenge of medical desert. So if there is a call from them, and if we were confident to put some health program money into this kind of action, I think that we are in the perfect place to make the best use of these results. I come from the team who has experts responsible for various countries. So each of us works on at least 3 member states. And yeah, that's my ambition, to share this knowledge with the colleagues so they are aware that they could feed it into their daily work. Otherwise, yeah, as I mentioned, we have Paolo here working on the very important project on health workforce planning. It's unavoidable that the conclusions from this project and the cluster overall should feed into what Paolo, under his lead, is going to do. Because yeah, we see different healthcare workforce planning models. I am not so sure that the issue of regional disparities in the distribution of healthcare professionals was a top priority, is a top priority. It depends. There are different models, but as I said as well, we have different health systems. So we have to always think of what is feasible in the given context. We also have George here working on the skills. Not only George, yeah, we have many other colleagues who are involved in the EU projects, ongoing EU projects. So I think it's also important to feed this work with the results of ahead when it comes to the education issues, skills issues. So we are trying to create the links. Yes, so that makes sense to us, of course, that. Yeah, we very much respect the nature of the project. This is a very much research project, but yeah, we have a research there to take a step forward and to see how we can make a difference on the ground. In terms of competence on our side, as I said, it's very difficult. It's a very delicate territory. But I think that, yeah, with all the goodwill we have in the team, I'm sure that, yeah, we can really draw interesting conclusions from this work and take it forward. So it's indeed our ambition. And yeah, all our actions on workforce are new actions. As I also mentioned, we are kicking off the training projects. This is actually a very dynamic process. So yeah, but we are trying to fit all the puzzles in something comprehensive.
Thank you very much. Dorota, then coming to you, you were speaking about the kind of differences of, there's such a wide difference between all kinds of rural communities. There can't obviously then be a one-stop approach because each and every one has different needs. So where do you then start essentially providing what people need in terms of their healthcare to the different areas that you're serving?
I think it's a question that wins you elections, really. So if I had the answers, then I would definitely be running for the next Belgian elections. As a locally elected representative, you normally know your community, so you know where to start talking to whom you want to talk. You want to talk to your citizen groups. You want to talk to your business representatives, but you also want to network with other democratically elected representatives from other regions to see maybe they've already tested some solutions on what works in their regions and what still maybe does not in yours. You also need to talk to your national government representatives to maybe lobby to change some legal provisions on, let's say, reimbursement of care or payment to service providers to make things easier. But also you may need to talk to colleagues in Brussels, maybe your regional representation here, maybe the European Commission, to see where there are opportunities for funding, what you can tap into. And it may not necessarily be strictly medical to start with, but maybe there's broadband connection, maybe you need the high-speed internet, and maybe there someone can advise you how to get that to your village. So once you have this foundations laid, then you can talk to your doctors to see, would you be open to remote patient monitoring, for instance? Can we agree that all the diabetics in our area would be from now on sending the results to you electronically rather than coming monthly or weekly for a checkup? But this changes will require a lot of involvement of people from all backgrounds, from different areas. And I've been talking just last week with our representative to the Pact, Radim, who's our vice chair, who was complaining that in his work, I mean, he's been working with LEADER and now also with the Pact on smart villages for years. This is something that he's very passionate about, being himself a rural mayor. Yeah, the fact that he's talking high levels of drone deliveries of medicine in his community, and he still cannot get the government in Prague to agree to this very simplistic sending details on diabetes care to the professionals so that they can adjust the levels of insulin onto the patients. So we really need to involve all levels in that. And I want to come back on one item that I had from both Kasia and John, primary care. Indeed, this is something that's really a starting point of any intervention, really. The best results, we've seen that during COVID pandemic, we've been looking at the survival rates across urban and rural areas. We're thinking, okay, well, we're just going to come up with a number to confirm that if you lived in a city, better for you because you get better access to care. Not really. Actually, in the first half of 2020, living in rural areas was a safer bet, and that's checking all, excluding all our differences. It basically, the difference was boiling down to having that doctor, that carer there that you were trusting. And then that translated into a certain higher acceptance of vaccine, or even doctors basically taking their own car and driving to patients they knew to say, I've got this vaccine now, I ask you to take it, you trust me, so please do so. And that's this is where it starts. It starts with this very privileged relation with the primary care doctor. But this relation you will have if you will have doctors. And we know that remuneration is one of the problems. In Germany, the difference between the a family doctor or a specialist, statistically speaking only, is about 20% in terms of rates. But I mean, in Belgium, it's already 100%. So it actually makes sense if you invest so much money into payable studies that you want to get the return on that investment you've made and maybe your family's made. And also there's this question of prestige we've been talking about. I mean, it sounds slightly better to say I'm a neurosurgeon than to say I'm a rural doctor. So of course there's also this dynamic to address. And a question of workload. And again, this is the question of skills. So you've been saying that people need to be super crazy multitaskers, not just on the medical side, but also on admin side, on digital side. I mean, a typical doctor in Poland spends less than 15 minutes on a consultation. And in that less than 15 minutes, 53% of time is spent on admin, on paperology. So this is slightly difficult then to get really excited about your vocation if you're just drowning in papers all day long. So that's just some of the consideration I wanted to bring.
This button. Okay, so listen, we've got less than half an hour left. So I think what would be a lot more interesting is, considering this is a consultative process, for us to take questions from the floor. So who's got questions for the panelists? Just raise your hands. Perfect, gentlemen at the end.
Hi, I'm George Valiotis from the European Health Management Association. Kasia, thank you so much for pointing to the work that we're doing in collaboration with many people here on the Be Well strategy, on upskilling and reskilling the health professionals of the future. I really want to thank the AHEAD project. Emma's been an advisor on the project, and it's been run so well. The speakers today, Your speeches were so amazing that not only did they remind me of the importance of the work, but they reminded me that I'm a person as well, because, you know, you forget that sometimes in the work. I remember, like, I'm from rural areas, and my grandfather, we live in Mount Olympus, right up on the mountain. Nothing is near us. 28 people in my mother's village and 2,000 goats. So to your point, Dorota. And when my grandfather was really sick, he eventually died, but when he was really sick, we couldn't get him to hospital. And so the way we would, it was the community. It was the neighbors with their vans and their cars. They're the ones who got him to hospital. And I think later when my partner was a doctor and when he was doing medicine, they wanted to place him in a rural area. And so they did. And he was the only, it wasn't working. And I said to him, what's wrong? And he said, not one doctor has made it through this placement, not one. 7 years of placing rural doctors, not one. Except 7 years ago, one person succeeded. And I said, what was the difference? And they said, he was married. And so I moved in with my partner into this rural area that I had no interest in being in for my own occupation. And we lasted the year together. But when I got sick, they wouldn't see me because we're gay. So the local doctor there didn't want to see, and didn't say that. You know, this was 15 years ago. Of course, they don't say that, but those are the lived experiences that we have. And it really taught me a lesson about it is the community that makes the difference in these rural areas. And Karine, you taught me well that medical deserts is more than just rurality and being in rural areas. There's medical deserts even in bigger cities. But really, my time living with my partner, who was a doctor in this rural town, although we were accepted partly by the community, they were delighted to have a doctor there. But culturally, we couldn't connect. Was it because we were gay? In part, but it was very difficult for us to connect. And so I would say, and is it Marina? Marina, it's so delighted to have you here in your comments because it has me thinking about really just rural areas and building community and how do we make sure that that community come together to help us find solutions. Because Paolo, obviously what we're learning in Heroes is we will not solve the medical crisis of the health professionals by recruiting more doctors and nurses alone. It's not going to happen that way. We need to think very differently. We need to engage with community differently. And certainly through the Be Well project, what we're learning is there's new occupations, new ways of imagining how healthcare is provided, and that's how we need to be thinking and looking. So thank you, speakers. It's so beautiful, such a wonderful day, and thank you to the Ahead Project.
Thank you, Aisel, for this excellent presentation. I think it became very clear that there's a wealth of conceptual development, analytical insights, but also a country work first-hand experience when the rubber hits the ground, so to say. And I would like to pick up what Kasia was saying, you know, how can others benefit from it? How can we make it more sustainable? And here I don't know if this is controversial, but bearing in mind, it's not the only one which is dealing with medical desert. I think we have at least 3 projects at the moment. There's Oasis with you, Paolo. There is Root HWF, which is also looking at it. They are looking at it at the same issue from slightly different perspectives, slightly different countries. And I was wondering, how can we actually avoid here confusion with policymakers? You know, which approach are they going to take? And I was wondering if there was the opportunity of synthesizing this a little bit in terms of a kind of policy brief with policy options where policymakers then can choose, as you say, John, and as you say, Dorota, not all policy options are for all rural communities, but you can say, this one is for us realistic, this one we will never achieve, this one, maybe in a couple of years. And I think that could really help and be an element in the sustainability and usability of these great projects. So we would offer to help you and provide the platform for this. As you know, we produce policy briefs for a living. Thank you.
Thank you so much. That partly answers my question. I'm Milena Šantić-Milićević from Serbia. I'm a part of the head project. So Serbia was a head country and is a head country. And I would like to thank all of you for very insightful speeches about the policy making process regarding medical deserts. I would not like to say that medical deserts should stay isolated issues. So not to desertificate further medical deserts in policy arena. So I heard here a lot of projects ongoing, which are in any or specific or direct or indirect way are connected to medical deserts, because medical deserts are the sublimate of all of these issues that you have mentioned, Kasia, very nicely, from the shortages, from Paolo emphasizing the retention issues, the planning issues, but also the agriculture infrastructural issues, the rural area complexities. And what we finally are here about is a cultural shift and how to make these local solutions, policy recommendations that we have in our mind, that we would like to pilot them and we would like to provide the effectiveness in our context of some of our policy issues in a year or in a 2-year or a 3-year, and how can we and how much interested it is for the policymakers at the EU level, since these are local solutions. So I'm very thankful to Matthias that he said that he would like to publish the evidence of their effectiveness, feasibility, and how they were managed at the local level. But since medical deserts are not isolated places, should not be also isolated at the political level as well from other projects, I would like to see somehow a synergy between these, not only between medical desert projects, but with other projects that are dealing with not only survival rate, but burden of disease of the people at the living in medical deserts and in rural remote areas, and also a cultural shift regarding the digital health literacy, etc. Thank you so much. That was my also appreciation for all of your speeches, and also a question how to move forward. Thank you.
I think, John, would you like to take the question? Yeah.
Yeah, I hope I'm not being too rude by kind of, but could I just make some suggestions from a training professional basis? And I'm not just doctors, these are nurses as well. And I think there are 3 stages that we should be looking. First is about this change in status. You know, we need to get rid of this narcissism about urban. And, you know, we need to think about that 30% of the population. So I think we need to kind of think about having rural health as a subspeciality in professional setups. You know, we've got family medicine, but I think we should have rural. I think, and I'm sure everybody would agree here, that every medical student across Europe should have lectures and also placements in rural areas. And in fact, there's a lot of evidence to show. There's a recent paper from Catalonia, which actually showed that very clearly. And there's some work in Australia that's from Queensland, University of Queensland, that said that. I think we need to give postgraduate people in training, we need to give them rural experience and rural training if we need to. We need to improve the provision of CPD. And I think we need to start thinking of taking the lecturers and the tutors out of the medical schools and putting them into the rural areas. So we have a network of rural tutors. So we have a network of practices that students can go and spend time in. I think we need to think about locum payments for rural doctors so that actually they can take holidays. We need to have a system, and in fact, there was somebody here that I met earlier on from another project, here we are, about supporting doctors, especially late career doctors. They're the ones that are burning out. And we need to have a system where every doctor can access, every nurse can access somebody when they're in trouble and burning out. And we need support for spouses and families. So that's my short term. Medium term is let's grow your own. This term has happened in Australia, it's happened in Canada. One of the reasons we choose medical students who are top grades, all 3 AAs in the UK, top in the baccalaureate, they're not necessarily the people who understand rural. So we need to start recruiting students from rural areas. Now, they may need help in the schools to get them through to that, but that's something we should do. We need to enhance the curriculum at university level, where they're spending up to a year in rural practice. It's happening everywhere else in the world, it's just not happening in Europe. We need standalone rural training programs for GPs, for doctors. And we need to have rural doctors doing PhDs, masters, so it gives them credibility. And we need rural research happening in rural areas, not in the cities, but in the rural areas. And finally, in the longer term, we need clinical medical schools. We need rural medical schools. We need rural research centers that are outside the cities. And you may think this is fanciful, but it happens and it works in Australia. And perhaps we need to start blurring that boundary between primary and secondary care. And the Australians have done this. They call them rural generalists. So they're trained as GPs, but they have additional skills. So there's a huge amount of work that's already happened in that. So look, you know, I think we have to be imaginative and we have to do things that are exciting. So finally, we have a blueprint in Eureka for the future of family medicine in rural areas. So please have a look at that. We're currently doing a survey to see what's happening in Europe. And the data coming through at the moment is lamentable. There's nothing happening when it comes to rural. And we have a conference and we're in Romania in October, all about rural practice. And so I want to see as many of you there as possible. So I'm sorry I've taken the floor, but I needed to say that. Thank you very much.
No, I just wanted to add as well, John, it's lovely to hear what you say about rural communities and the rural health service, because as someone that grew up in a tiny village, I found that the healthcare provided in rural areas is actually much better than in big cities. But perhaps that's just the UK, I don't know.
Bologna showed that the rural training was better and people considered it better than the urban training. But when they came to the end of the training, they went back to the cities because that's where their families were.
Okay, just quickly before we go to the floor, I'll let Paolo to react.
Okay, just a short react to what John just said. Of course, I agree with you in principle. Okay, just to underline that, well, first of all, this requires a very effective change management. Okay, because the major risk, you know, when we plan for the health workforce, for the health system, is to maintain the status quo. Okay, so the real challenge also for policymaker and politician is to manage the change, and also we needed to focus also on the sustainability of the measure in which we are going to invest, and to keep also the quality of the training and the quality of the healthcare that we are going to provide. Just to highlight those points. Thank you.
Thank you for the floor. I'm Nicolas Serli. I'm at the Brussels office of the Piemonte region. I'm addressing my question to Paolo Michelutti. It's not because it's the easiest name to pronounce for me, I swear. And my question is, if we take into consideration the upcoming healthcare workforce crisis in terms of shortage, of course, the first thing that we think about is education. We need to educate more nurses. We need to educate more doctors. Of course, you know that that would not be enough, because we need to provide them with the right skills. And that, of course, would mean also digital skills. And that is because right now we are developing solutions and technologies that allow us to provide for a better care with reduced costs. But if the doctors are not able to use these technologies, they would be useful, wouldn't they? So my question is, do you think that we are doing enough to put the digital skills in the curricula, in the study curricula of the health workforce? And if we are not doing enough, what more should we do? Thank you very much.
Thank you for the answer. I'm not sure that I can give you so thank you for the question. I'm not sure that I can give you the right answer. So I'm not an expert in education. So I do not know if in all the countries we are doing enough to improve the digital skills on all the health professionals. What I know is that there are a lot of initiatives also at the European level, of course, to improve the digital skills, to improve digital education. So, of course, there are a lot of this kind of initiatives. But again, I think that is an issue of trying to change the curricula. And well, we know that it's very difficult to, especially when we talk about the university, to change the status quo. Okay, so yeah. Yeah. No. Okay. Well, just okay.
Well, my name is Dana Fărcășanu. I'm a medical doctor leading the Center for Health Policies and Services, the AHEAD partner organization in Romania. First, thank you to our Italian colleagues for organizing, for allowing us to speak here, to be part of this meeting. We discussed a lot of technical problems and solutions during this meeting. And I would like to take this opportunity to share some asks we might have based on our findings at the national level from the EU Commission, from the Parliament. We discussed a lot about the healthcare workforce, which is important. But if we change the perspective and look from each and every citizen, either in a rural or urban municipality, about their rights to health and healthcare, I would first challenge Paolo. We need data. I'm not. We are a non-state actor, right? But a technical one, a good one, I would say. We do not have access to disaggregated data. We built for this project and for the innovative tool we developed our own databases from 42 health insurance funds in 42 counties, looking at the GPs in contract with the health insurance. We built our own databases. I would like to see in Eurostat database each profession, each healthcare workforce professional, disaggregated data at the most smallest rural municipality level. I would like to see the doctor, the nurses, other allied professions, psychologists, community nurses. In this way, we would be able to inform, to build evidence, to inform the policymakers, not only in Romania, but also here. This is my first kind request to consider by all DGs, by the European Commission. We need data. Otherwise, if we count always on the data aggregated we have, we quote data from data, old and outdated and useless. Secondly, we cannot build cross-sectoral programs. We have a lot of funding, and we are very grateful to the European Parliament, to COVID epidemic, for providing us the opportunity to have this recovery and resilience programs with huge funds for infrastructure. We need infrastructure in Romania at least. But we also need cross-sectoral actions. And if the Commission, who's giving the direction to our national governments, do not initiate cross-sectoral program in Agri, in regional committee. Let's organize, Sante DJ I know is doing that. Let's do thematic meetings. Access to health and healthcare for our citizens. Invite people from other directorates, general directorates. I mean, raise this first movement to change to do the mind shifting among our local authorities and other stakeholders and create, I don't know, a cross-sectoral approach. And last but not least, and I'm over, please monitor and evaluate. We cannot implement without looking if we do have change and results. And do that not only with the state actors, but also with your independent groups, with the professional organization. Thank you very much. We have a lot. Thank you, Katia, for the wise companionship of the project and the inputs. We shared a lot and we will keep doing even if the project ends in May with our stakeholders and policymakers, our findings and informed recommendations. And thank you for listening. And I do hope we will not have only another project with some good results and it, but we will have findings to feed the next joint action programs and all other initiatives. Thanks a lot, Mariano. Thanks a lot, lady.
Would perhaps one of you like to respond or? Yeah, Marina, let's go. Go ahead. Oh, sorry.
Here we go. Yeah, I might say something. Now, it's very interesting what you were saying, also to your intervention previous to yours on the policy options, because there is something we're trying to conduct at EU level, and we are inviting also member states to do, is this rural proofing. This rural proofing mechanism that seems analyzing legislative and non-legislative and the rural lens. That means for a implementation of any action, what is going to be the impact in rural areas? What do we need to do for this initiative or this measure to have a real impact or not a differentiated impact between rural and urban? And that brings me to the next topic of data we have highlighted. We might have data at the member state, but we have a rural observatory now set up in which you can have data at municipal level. That's what is defined at Eurostat level, rural areas. And in this municipal level, the problem is we only have, I was checking, and is average distance to healthcare facilities. And I was talking even to my colleagues in ESTAT saying, okay, it's not the same specialists and generalists. So we have this challenge. And we acknowledge that. We're trying to work with Eurostat, specifying like, okay, we also did a publication on rural Europe, which has and brings more light to rural areas, well, not only rural areas, because at the end there are just comparison between cities, towns, and urban. So I wanted to highlight these two elements, and thank you very much.
You want to? Yeah, go ahead. Yep, go ahead. Yeah.
Okay, there it is. Sorry. So mine was just to contribute to a response to the gentleman who asked about training. So that's what the Be Well project exactly is looking at. It's looking at curriculum development. There'll be and in fact, it was colleagues of Matthias who have been doing scoping reviews of curriculums of the future professions. So if you did want to look at how our professions are merging, what are university frame, university competencies, all of that's being factored. It's the bewell-project.eu where you can find that information. They'll launch their strategic plan in June. And the scoping reviews that colleagues of Matthias have done will be released there. In terms of medical deserts and rurality, in fact, to John's questions, it does have me thinking about how our skills for rural people working in rural areas being factored in, and this very meeting motivates me to go back to those reviews and see where they might be factored, where we can improve that, because although it's focusing on digital and green skills, the other thing that of course we're identifying is in order to improve those, the people skills is what you also need to focus on. So where do rural skills and people skills fit into that? I'll revisit that. So thank you for the motivation.
Any more questions from the floor from anyone? No, okay then. Okay, well then I'll hand back over to our MEP for some final sort of closing remarks.
I just had a comment actually, and a political provocation, to be honest, because my grandfather was a medical doctor in a rural area. He was class 1900. So he was in a small village in northeast Italy, having 12 different, different villages under the main, his responsibility. And of course, he was the first one to get a motorbike because he had to use the motorbike, to reach all the villages. And he was also the first one to get a car later on, because he needed the car again to reach, the farmers lost in the mountain villages. So the political provocation is the following, in terms of medical desertification and addressing the new frontiers of telemedicine, we should actually prioritize those doctors and have those doctors, those GPs, being the first getting the new technical equipment and being the first getting the smart connections. So we should try, it's extremely different, but it's logical to invert the paradigm, and try to have at least some pilots, I think, in rural areas, also for instance, the new legislation I'm responsible for my group, with my group, which is, the gigabit connections, for instance, gigabit infrastructure. You need a lot of data, you need, very fast streaming. So I just thought, and I want to share with you this image of having, a motorcycle, having the car to reach out patients, and today, the way to reach our patients is actually, telemedicine sometimes and very performing and high-tech instruments. So I want to thank you very much again for this inspiring, thoughts from my side, and keep counting on me, in the future to raise the attention to these issues in the Parliament. Thanks.
Thank you so much for allowing us all to be here as well. Thank you so much. Okay, well, with that, I think we can just hand over now to Corinne to wrap us up. Go ahead, please.
Yeah, wow.
And you can have the mic. There you go.
Thank you. Yeah, no fiddling with the buttons.
No this time.
Yeah, this is a huge challenge, of course, to summarize or round off a 2-hour discussion that was really, really rich. I really appreciated all of you here and sharing your experiences, professional, personal, and whatever. I made some notes and I circled a couple of key things that I thought I want to bring this back in rounding it up. Mrs. Kovasi's words in your starting of the meeting, urgent and importance. I think we all here around the table are convinced that this topic that we are discussing is urgent and important to address ASAP, so to speak. Agree on that. Then I circled so many familiar faces. It was you who said that. And I was also like, wow, we have a full house here today with many familiar faces. I'm really, really glad that you all made it here. But there are also a couple of unfamiliar faces. And I'm very, very grateful for them for having accepted our invitation to be here. And I'm especially looking at the opposite of the table. But there is a couple of others here also, because we need to liaise actually much more with the unfamiliar faces, break out the silos. It's your mantra, I think. So, I mean, we need to broaden this circle actually and get more and more people in and unfamiliar faces so that they become familiar and we can liaise with them, exchange with them, talk with them. What else did I wanted to say? Yeah, a word by Paolo, tricky. You said something at some point, it's tricky. Because when you want to engage with different stakeholders you do not know so well, stakeholders who have not been really involved in policy dialogues before, like what AHEAD has done, it can sometimes be very tricky. It's arduous work, really, and sometimes you're in this minefield of interests and prejudices also. But I think we've made it work in the AHEAD project. It's quite difficult, but it's very rewarding. And because when people from different angles and walks of life talk to each other and treat each other with respect and respect each other's perspectives, you first have to make contact in order to steer in a certain direction and improve the situation as it is. And that again relates to what John said about we need so much time. You have to take in mind, and you said that also, Paolo, by the way, you need a visionary action that takes time. You have to have a point on the horizon where you want to go. And again, if you want to bring people in the circle, make contact with them, and go together in that direction, you need also a lot of time. And for the change management, that is also a very, very important one, including for introducing the whole digital aspect of medical work, or care work, I should say, primary health care. It requires time, it requires patience, but once you are in dialogue with your stakeholders and you have built the trust, you can move together. And you can even explain, I'm certainly convinced of that, you can explain why at some points you make difficult decisions that may not be so popular. But when you are, like, we have a point on the horizon, that is where we want to go. We want to abolish these stupid health inequalities, and we will all have to, well, make some sacrifices maybe, but we're all heading in the same direction together. I think really that is the way to go. I am really proud of the team of AHEAD, that we have made it work. I'm happy with your suggestion, proposal, actually offer, to help us also in connection with the other projects to synthesize more of the results that we have. I think that is a very nice idea. Thank you very much. We will certainly make use of that. And another great quote from another great colleague of mine, Milena, not so long ago, you said in a meeting, like, AHEAD is coming to an end, but it's not a full stop, it's a comma. Because we are all now so involved and connected in our respective contexts and countries, we will most definitely be involved in future developments, either in our own countries or at the EU level. So I'm really proud of that we made that happen. I'm also very certain that the momentum is there. You hear it all around. 3 years ago, when the call came out, it was like medical deserts, what is it? What do we understand by it? It's a buzzword. It has become a buzzword in the meantime. So in that sense, non-stop, forward and forever, what was it again? This motto that we had at some point. Thank you so much. I'm counting on all of your efforts and passion for this topic. I'm very thankful for many of the people here around the table who have helped us in many different capacities. And I thank you for being here, and I look forward to seeing you again. Thank you.
Perfect. And with that, I think this session is a wrap.
Great. Thank you, Mary.
My pleasure.